Good morning, my name is Joanna Jiang. I'm an R3 with the CCFP-EM program for those who I haven't gotten the chance to meet yet. Today, for my critical appraisal topic, I'll be presenting on the prevalence of pulmonary embolism in the ambulatory patient with COVID, of course. Okay, so with the end of 2019 came the emergence of SARS-CoV-2, which at this point is a virus that needs no introduction. So our knowledge of this virus is continuously evolving, and today I wanted to focus on a particular diagnostic challenge that we face in the ED, which is diagnosing pulmonary embolism in the ambulatory patient. We know that COVID-19 incurs a high thrombotic risk, and that's multifactorial. There's the mobilization from sickness, there's the direct endothelial damage and activation, and there's also a change in the coagulation factors to be in a hypercoagulable state. And so there's a lot of literature that's mainly about inpatients. There's very little data that exists about the ambulatory patient in terms of incidence and characteristics of this patient population. And just as a reminder, as we've all seen before, COVID presents in different phases. The first phase is really the viral response. And then as you hit day 7 to 10, if the patients do get worse, they fall into a host inflammatory response. And so what makes the diagnosis difficult is that there's overlapping symptoms between pulmonary embolism and the respiratory symptoms of COVID, but also our clinical tools that we're used to using, like the Wells and the PERC, they were not validated for the COVID population. And as well, the D-dimer, which as we know is not very specific, can be increased by many things, including inflammation and viruses, including COVID. So we don't know at what threshold of D-dimer are we specific for pulmonary embolism. Taking all of that into consideration, we're faced with a difficult challenge to decide who should undergo a CTPA. And given the resource utilization, we cannot make everyone go under a CTPA, and it would not be right to our patients either. Because as we know, the test is only as good as the prevalence in the population. And if it's a low risk population, we really risk having more false positives, which exposes our patients unduly to the risk of irradiation, but as well as the exposure to treatments. And in this case, that would be bleeding from anticoagulation. False positives can arise from many causes. The CT diagnosis of filling defect, so things like breathing motion artifact, poor contrast opacification, and adjacent airspace diseases are all sources of false positives. And of course, in the context of our pandemic, infection control is very important as well. If you submit a patient to a CTPE, they are likely going to stay in the ED. They can stay up until 6 hours to get their results. That puts your personnel at risk, the patients around them at risk. And if the patient itself, if they're waiting for a COVID result, if they're not positive, they might catch it while waiting in your ED. So with all of those things in mind, I decided to do my CAT topic on this subject. So I did a COVID Medline search with 3 main topics using mesh terms and keywords to look for the key terms COVID, ambulatory population, and pulmonary embolism. When I say ambulatory, I really mean basically any patient that presents in the ED, so it's non-hospitalized patients. And I really wanted to specifically look at pulmonary embolism, given the overlapping clinical presentation. Exactly. So with that search, there was around 55 articles, so very little. And then when you filter out for the ones that are actually relevant, there really weren't many. So I'll try to get through at least the 4 retrospective studies and then quickly go over the 4 case studies that I found. In terms of the common limitations that the retrospective studies present, of course, there's the study design itself. But other than that, all of the retrospective studies were done on data that was quite early in the pandemic, around March to May of 2020. At that time, there was a lot of new data, a lot of changing protocols. So likely there was a variability in the knowledge of different physicians. Perhaps there was more practice variability. And this is pertinent because in those retrospective studies, there was no systematic screening. So it was really the physician who decided if they were going to do a CTPE. Otherwise, other possible sources of biases are the patients themselves. At the beginning of the pandemic, there was a lot of uncertainty. A lot of patients were not going to the hospital, so perhaps there were more late presentations, all things that might not be as representative of our current situation. So for the first article, it's called the Acute Pulmonary Embolism in Non-Hospitalized COVID-19 Patients Referred to CTPA by Emergency Department. So the title is really quite, is basically the summary of the objectives. So they're really looking at the prevalence here. The inclusion criteria were patients who were diagnosed with COVID-19 who underwent a CTPA in the 1 month period of March, April at the beginning of the pandemic. So what they did first was look at all of the patients who the physician had decided required a CT scan for suspicion of COVID pneumonia. So that was around 211 during that period. And then amongst those patients, there were 146 patients that were confirmed COVID positive. So that's either by PCR or by clinical suspicion with CT findings. And then from those 146 patients, the physician decided that there was 72 of them that required a CTPA to rule out pulmonary embolism. And the data I will present is really about those 72 patients. So amongst those 72 CTPAs, 13 of them, so 18%, were positive for pulmonary embolism. In terms of the COVID status of those 72 patients, 58 were confirmed by PCR, whereas 90% were diagnosed based on clinical suspicion and CT findings. Of note and of interest, really, these patients were more sick. If you look at they categorize the severity of clinical severity. And so 31 of those patients, around 43%, were considered moderate, which by their categorization meant that they either had fever, respiratory tract infection, respiratory tract symptoms, or pneumonia in imaging. And then 57% of these patients were either severe or critically ill. So for severe, that's a patient that has respiratory distress, a rest rate of more or equal to 30 times per minute, who required O2 and who had a PaO2 over FiO2 less or equal to 300. So that's at least mild ARDS. Or they were critically ill, which is patient in respiratory failure, requiring mechanical ventilation and shock, or ICU monitoring. So this population was really quite sick. If we look at the statistically significant data points, in terms of age, the patients that had PE were older than the non-PE group. So there was a mean of 74 years old for the PE group versus 59 for the non-PE group. Other values are statistically significant are the D-dimer. Oh, sorry, the D-dimer was not, but it does show in the PE group to be 2 times higher. Other interesting data points is the fact that both groups presented around 8 days after onset of symptoms, 8 days for the PE group and 7.5 for the non-PE group. And if we look at the clinical severity in the PE group, there was slightly more severe critical disease, so 62% versus a 56 in the non-PE group. In terms of the symptom, there's not that much distinguishing factors. The other statistically significant value was the D-dimer, sorry about that. So that is less than 0.05. So it was the age and the D-dimer in this group. In terms of limitations for the study, of course, it was a small sample size and it was also a single center. There was a selection bias for more sick patients. First they selected for patients who they deemed needed a CT C-, and then later patients who needed CTPA. Unfortunately, there was incomplete data collection, although the D-dimer was statistically significant. In both groups, only 50% of patients had D-dimer values. And there's likely, with the selection for CTs, like I mentioned earlier, there was likely some practice variation amongst physicians. And they did also rate the quality of the CTs, and unfortunately, there was a significant proportion that was deemed unsatisfactory, equal in both groups though, in the PE and non-PE groups. And for them, unsatisfactory means that the image was not allowing a correct interpretation of all the pulmonary arteries. So likely for the segmental and subsegmental, it was a more difficult evaluation. However, it was really a small sample size and underpowered to really evaluate the differences in characteristics. However, I do think the inference that we can draw from this study is that in the moderately to critically ill patients for whom you do have a suspicion of PE, the rate is quite high. The prevalence is quite high, around 18% in this study group. There was also a statistically significant difference in D-dimer, although the data collection was incomplete. And I think it is interesting to note for the study that both groups are around 8 days post-infection, so they were in the inflammatory host response phase. For the next study, it is quite similar as well. The same objective was to find the incidence of acute PE in patients undergoing CTPA in the ED. This was a study that was done in New York in 6 different hospitals. The difference was this was a retrospective cohort study. So the inclusion was patients that were over 18 years old who underwent a CTPE, but they compared 2 periods, the same periods in 2020 during the pandemic and in 2019 pre-pandemic. In this study, to be determined COVID positive, it was either anyone who was known previous to the visit or at the time of ED visit, and within 2 days of the CTPA. So they really wanted to capture the quote unquote outpatient population. In terms of results, this was a larger study. So in 2020, there was 464 patients that underwent CTPA, of which 87 were positive for pulmonary embolism, versus in 2019, where 446 patients underwent CTPA and only 7.6% were positive for PA. And this is a statistically significant difference. So there was a lot more in 2020. In terms of the COVID positive prevalence, we see 49 patients of the 87 patients were COVID positive by PCR. However, if you take into consideration the patients that were clinically suggestive and had CT findings, plus the PCR, we have a rate of 72 over 87. So that's around 83%. So if you do the math, that means in this COVID negative category, there's around 10 patients that were PCR negative and who did not have CT findings. That is still possible that it was a false negative. However, it's hard to know. I will still be mainly looking at the all patients category, but if you look at the comparison, they're quite similar in terms of their characteristics. So once again, if we look at the ages in the COVID positive group, the mean age was 57. So it was younger in this group compared to 2019 where the patients were older, 65.7. Here we see that the males are more represented, 59% in the PE group of 2020 versus 35% in 2019. Of interest, these patients did not necessarily they had less of a history of PE DVT in 2020, and they had little physical exam findings for DVT, only 9% in the 2020 group compared to 26% in 2019. So different clinical presentations here, and they were a little bit more tachycardic in 2020. Otherwise, we also have the D-dimer here, which is not statistically significant, but still interesting to note. In 2020, 96% of patients had an elevated D-dimer compared to 82% in 2019. Unfortunately, they don't kind of break down the different D-dimer levels, which would have been interesting to see. And there wasn't really much of a difference in terms of hospital course or disposition. So the limitations for this study was that they didn't mention what the patients presented for the CTPA indication. They didn't mention the clinical severity of these patients, nor the time from onset of symptom. And once again, there was also the bias that the physician was the one who decided who needed CTPA, so there was likely variability between staff. Another limitation is that there's 10 COVID negative patients that were included in the characteristic analysis in the 2020 cohort, which could have been a source of bias. However, this was a larger study. It was done in multiple hospitals, and it showed results that were similar to the previous study, that in a population who is more sick, who you think is at risk of PE, that you would request the CTPA, prevalence is around 18.8% in their study group. They also showed a statistically significant increase of thromboembolic events in 2020, from 7.6 in 2019 to 18.8%. The next study is called the Incidence of Venous Thromboembolism and Mortality in Patients with Initial Presentation of COVID-19. So this is really looking more at all comers coming to the ED. This was done at the Northwell Health. It was a multi-hospital system. The inclusions were anyone above 18 who were diagnosed with COVID-19 during a 1 to 2 month period at the beginning of the pandemic as well. They excluded obstetrics and gynecology admissions, however, they didn't explain why. And for them, the VTEs had to be image confirmed, but they also, they had a combined primary outcome. So they included patients that were VTE positive, but also patients that died within 8 hours of presentation. With basically the thought is if the patient was very sick, likely they had died from a VTE complication. If we look at the results here, so they really had a very large group. The COVID positive group was 10,871. Of those patients, there was 28 that had died within 8 hours and 118 that were diagnosed with VTE. So for a total of 1.3% prevalence. And of the VTE, really the majority were PEs, 101 out of 118 versus 17 DVTs. We also see that there's a male preponderance here. And in terms of the previous medical histories, patients were known for hypertension, 46% of them, and diabetes, 24% are the most common. And it's interesting to note that 92.5% of the patients did not have a history of VTE. They also looked at the D-dimer levels. Unfortunately, 38.3% of patients did not have a D-dimer level. Of the ones that did get a level, 51.4% were 6 times above the upper limit of normal, which is more than 1,434 in their study. The patients were also characterized by their comorbidity index, by the CCI index, with more than 2 being considered a medium comorbidity. So in their patient population, at least 59% of their patients were medium comorbidity. They also mentioned that there's a significant association between statin use and antiplatelet use, claiming that there's reductions of 45% with statin and reductions of 30% with antiplatelets. Unfortunately, they did not show any of the absolute numbers associated with patients who had negative VTE, who were negative for VTE. So we really don't know what those absolute numbers are, and we can't make any conclusions from that. So the limitations of the study, they didn't have any statistical analysis for their results. There's a lot of missing information. How many patients underwent imaging? What was the time since symptom onset? What was the severity of these patients? And what was the indication for imaging in them? And it would have been interesting had they compared the demographics of the patient who were negative for VTE with the positive cases. However, this was a large sample size study, and it was looking at more the overall incidence of all comers, which is useful for us to know. So in this case, it was around 1.3% of VTE in all patients presenting with COVID positive. And what's interesting to note is that in their population as well, there was much more PE, less DVTs. In terms of the patient characteristics, I think it's a little bit more difficult to comment on. And for the last retrospective review, this is similar to the previous study as well. They wanted mainly to assess the frequency of arterial and venous thromboembolism up to 30 days. So it was a little bit more extensive in terms of the patient population as well. They looked at 10 different hospitals and several outpatient centers. It was one of the few studies that was looking at outpatient centers. They had a total of 1,114 patients, also over around a 1 month period at the beginning of the pandemic. They included all patients that were 18 or older with laboratory confirmed COVID-19. And what they did in their study was they made 3 mutually exclusive categories. So the patients were divided into ICU candidates, non-ICU patients, and non-hospitalized patients. What is important to note here, though, is, for example, if you were non-ICU category, if you were just need 1 or 2 days in the ICU, you automatically fall into the ICU category because it's mutually exclusive. So we'll talk about how that might cause some issues later. But this was really a very extensive project. They did an exhaustive EMR review. They looked at 30-day outcomes for a lot of different outcomes, looked at demographic information as well. We will focus mainly on the outpatient sector. And in terms of their follow-up, they were really quite successful. 96% of their study cohort had a 30-day outcome follow-up. Unfortunately, for the ones that were missing, most of it was in the outpatient category. 40 patients in the outpatients were lost to follow-up, so around 5.6%. So if we really focus on the outpatient category, we see that the patients are younger with a mean age of 44.8 years old. And then as you get to the sicker categories, they're older. We see in the outpatients, there's more females, but then as they get sicker, once again, there's more males. Otherwise, BMI, there was not really a significant difference. In terms of the associated medical issues, hypertension and cholesterol were the most common in our outpatient setting, very little of the other comorbidities. And in terms of prior VTE, very low as well, 2.7%, only a little bit higher in our inpatient population. And then of interest, these outpatients presented a lot with shortness of breath, 31.9%. presented with dyspnea, and 6.7% presented with chest pain. The most common complication in our outpatient population was COVID pneumonia, around 9.5%. And then if you look at the thromboembolic event, both arterial and venous, in our outpatient population, there was none. And I suspect that's due to this is part of the limitation of the study, is due to the exclusive categories. Likely, if a patient that was an outpatient developed a significant VTE, they probably fell into the hospitalization category. But I think it's still important to know that in this category, there was 715 patients that over a course of 30 days from diagnosis did not develop these complications. Otherwise, in terms of death or other outcomes, there was only really death in the outpatient category. There was 2, and these were 2 patients that were septic or had ARDS, and they got very sick, and they transitioned to palliative care without being hospitalized. So like I said, the limitations was really due to the fact that they were mutually exclusive study cohorts. So I suspect it's underestimated the rate of VTE, arterial and venous thromboembolism. However, like I said, it's really a large study, and we have a large part of that outpatient population likely is low risk. Unfortunately, for the loss to follow-up, a lot of the patients fell into the outpatient category, so that is also a possible source of bias. The advantages of this report is that it was very detailed, large sample size, and diverse setting, one of the few to really show patients in the outpatient clinics as well. So I get the inferral that we can take from this research is that, from this project, is that likely there's a significant portion of outpatients that will not develop PE and DVT if they have mild symptoms. And this despite the fact that they may present with dyspnea or chest pain. I'll just talk quickly about the case reports. I won't go into them in detail, but there was 4 case reports, 2 of which had multiple cases in it. The recurrent theme is really that these are often young patients who have minimal risk factors. They often present within the first viral period of their infection. They'll become less symptomatic or even asymptomatic. And then by week 3 or 4, often they would present with new symptoms or worsening symptoms. Often when they present, there's very little. There are sometimes vital sign changes, but it will often be just an isolated increase in heart rate or an isolated increase in rest rate. The D-dimer was often positive in all of these patients, and then they were diagnosed with PE to variable degrees. So many cases of this. Here it was a patient 12 days post-diagnosis, another one 15 days post-diagnosis, elevated D-dimer. There was one case study, a case series where patients were more immobilized that also presented with both DVTs and PEs. Here we see dates from 16 days to 23 post symptom onset. This is the one with immobilization. Patients were immobilized from 14 days to up to 30 days just due to the sickness, the illness. And they all presented with elevated D-dimers and were diagnosed with thromboembolic disease. So perhaps this is a type. Of course, these are only case reports and case series, but a hypothesis that perhaps in these young, healthy, minimally symptomatic patients, to keep an eye on the fact that if they represent with worsening symptoms or new symptoms in the 3rd to 4th week period, you have to look out for PE. So what do we make from all of these studies? So like I mentioned, we are quite limited by the number of studies that were available and also by the limitations that they had. Although I don't think we can make any solid conclusions from them, I think they are at the least hypothesis generating. So like, as we already know, the more sick the patient, the more likely they are to have thromboembolic events. And I think that's the same for our ED patients. So if we have a patient that is clinically unwell or they are clinically deteriorating, in that population, the incidence of a VTE in patients that do undergo CTPA is probably around 18 to 20%. And often these patients will present at least 1 week post-symptom onset. These studies seem to suggest that males are more affected than females. PE seem to be more common than DVT. And perhaps this is in relation to the pathophysiology. This is not patients who get clots in their legs and it goes into their lungs. It's more of an immune reaction. So perhaps it's more accurate to call them pulmonary thrombus. This is really secondary to the endothelial damage and to this uncontrolled inflammatory reaction. So is PE really a complication of COVID, or is it just part of the spectrum of disease that the sicker you are, the more inflammatory you are, the more likely you are to find these thrombus? And then if we look at our last 2 retrospective reviews, the overall incidence for all comers of all severity mixed together seems low, around 1%. And so perhaps in the low risk ambulatory patients, so someone who is young, who you don't think there's an indication for hospitalization, and especially if they're early on in infection, likely they probably have a low risk of VTE, even if they present with dyspnea. There are probably different risks also depending on what time you present. And I wonder if the D dimer is also correlated with the stage of disease. So like I said, this is really to be taken with very large amounts, large grains of salt. The evidence that we have is not that great in terms of quality and in terms of strength. So these are all hypotheses that are to be explored in future studies. We really need more large-scale research to try to characterize the patients who have PE in the ambulatory setting. What is the time from onset usually? What is the incidence and prognosis in these patients? It would be interesting to see if there is a D-dimer cutoff at which we should be more worried for pulmonary embolism. We should check for the validity of our clinical tools like Wells and PERC, although I suspect Wells probably will not perform as well given the low rates of DVT in this population. And then once we have a better idea, what are the therapeutic, the prophylactic options that exist? So I listed some of the ongoing studies. I'm sure as time goes on and our understanding evolves, we'll have a better idea as well. And so that concludes my presentation. Thank you, and I invite any questions or comments.